This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of prehospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together, no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're going to do something slightly different and start to look at compilations of series we've put together on the podcast. So this week we're going to look at palliative care, and we're going to look at episode 1, 2 and 3 and really just the highlights from those episodes in the following audio. Next week we're going to look at trauma, then we're going to look at paediatric care, then geriatric care, then we're going to look at grief and the compilation we put together there. So what we're going to do is really amalgamate and highlight some of the fantastic episodes and the topics we've covered and condense them into one episode. If you'd like to go away and listen to the actual individual episodes themselves, they will be in the show notes. Together this week we're going to put episode 1, 2 and 3 together for the compilation. Episode 4, which is a palliative care case studies, you'll find in the show notes if you want to go away and listen to that fantastic episode with the palliative care team. So we just really discuss the key concepts of palliative and end-of-life care along with dedicated specialist teams. We examine the difference between specialist and generalist teams, but we also look at different tools. Then we take a closer look at the final year of life in the prehospital setting, and we also explore indeed the NHS Long Term Plan, but also some of the logistical barriers that complicate effective advanced care planning, and also some of the emotional support clinicians provide to the family. But also in this compilation, we really look at what that dying patient looks like in the final few hours of life. This really is a patient-centered conversation and compilation. So this series really closes by reflecting on the cultural diversity, but also the language barriers, and also just that we need to be compassionate, patient-centered in our approach to palliative and end-of-life care for every patient and every family. I hope you find this series and the future series helpful as an amalgamation and compilation of some of the received wisdom from our guests. Okay, please do enjoy.
It naturally goes against a lot of our instincts as paramedics and ambulance clinicians to see someone that is that unwell, that is actively dying, and not do something in terms of transport them to hospital or do kind of invasive interventions. Obviously, we can do a lot for these patients, but getting people to build in that pause whilst they figure out and gather more information and history, I think that was a real challenge because culturally that wasn't where we were at the time. So I would say that that's probably the biggest thing. Is there anything else you'd want to add about educational gaps, Jodie?
I think, well, building on from the gaps was the gaps in the services we had to reach out from, and that really aided our education as well. So the gaps we had was originally, I think, was it just one team that we would refer to at the very beginning, and now we've built up sort of 25 plus referral pathways across London, and we've really worked hard on keeping really strong engagements with all the palliative care teams across London, and that allows for us and our crews to reach out to them when they are with these patients where, like you say, the specialist teams have built that really strong relationship with these patients. They know the history, they know the family, and then we parachute in. But now we can bridge that gap by calling those teams. We have those numbers available to us, and that really increases our confidence in the fact that we're not, when we are on scene, we know we don't feel like we're on our own because we know we can call these teams for support.
And I think on that point, I think that's really important, is prior to our team being around, I think ambulance clinicians felt like they had to make these really big decisions on their own because there weren't those pathways in place. And we're quite used to, aren't we, working on our own and with limited information and making decisions, whereas actually that has been one of our key messages, is shared decision making is so key. You don't know these patients, you don't know their background, and actually, as you rightly said, they're often complex situations. So that's a real big takeaway point, I think, throughout all of our education. I think your point about these patients slipping through the net is really key. I think that's going to become more and more the role of the ambulance service, is being the first kind of clinicians to identify, well, actually, this patient is likely in the last 12 months of life. So we do absolutely promote some tools within our service. So there's a couple of different ones. Our preferred one is the SPICT tool, so the Supportive Palliative Care Indicators tool. So this is a tool that helps to identify patients with deteriorating health and help identify that these patients would benefit from some palliative care intervention, whether that be specialist or generalist. And the purpose of it is to identify people earlier on in those 12 months, because I think what we find all too often is these patients go and go and go until they're kind of actively dying or in the final months of life, and actually they've missed so many opportunities to try and prevent some of these symptoms, to try and improve quality of life. So that's the purpose of the tool. It has been validated in hospital setting and in primary care settings. It's not yet validated as such in the pre-hospital setting, but it is encouraged its use, and it's a really quick, easy tool that we've had really positive feedback from ambulance clinicians about, because it is super quick and easy to use, given that we sometimes have limited information about this and how it works. I'd encourage your listeners to go have a look at it if they hadn't heard of it. But how it works is it just asks you, firstly, you'd be using this tool if you suspected someone was in the final 12 months of life, you had that gut feeling from your interaction with them, and then you look for general indicators of decline. So if the patient has one or more general indicator of decline, you move on to the next bit of the tool, which talks about specific clinical indicators of decline as per their disease progress. So an example of a general indicator of decline is unplanned hospital admissions. That would tick you to go on to the next part of the tool, and then depending on what kind of advanced or life-limiting condition they have, there would be another one or two factors you would need to tick to make you see that this patient was likely in the final 12 months of life, and you need to start thinking about making a referral to the GP, highlighting it to the GP, or potentially, if you are conveying them, highlighting that with the ED staff. So an example is dementia frailty patients. A specific indicator of the decline is eating or drinking less, double incontinent, things like that would make you think, okay, this patient is showing a couple of signs that they're in the final 12 months of life, and perhaps we need to be involving the GP more if they hadn't already kind of identified this patient as such. But I think that is absolutely a role that we are going to be doing more and more with the ageing population, with the kind of restrictions around funding for hospice teams and specialist teams, and the GPs being completely maxed out with their workload. I certainly see us having a really vital role in identifying this patient group a lot more.
And the simple, like the question is, this person was to die in the next 12 months. And that's such a simple question that I think we're frightened of pre-hospital. If we're asked that question when we commit and say, well, yes, I think this patient could die, we feel we shouldn't cross a boundary almost, but it is we are so well placed as ambulance clinicians to be highlighting and identifying these patients early. And like what we said, they're not being captured early enough. We are a massively aging population. We are captured, of course, the cancer patients and malignancies, they are captured. It's the organ failure ones that we're not capturing early enough, and they are missing out on really good palliative care that would massively enhance their life. So it is up to us to be using these tools, educating, because they are so simple. They're really easy to use. It's just you're just looking at a couple of little questions and saying, yes, that this patient ticks that box, So it's likely they're in the last 12 months, nothing more than that, and highlight that to the GP so they can start putting the plans in place, start having conversations with the families and the patients themselves that's missed. We're not giving people opportunity to know that actually their life may be coming to an end. And so what conversations do we need to have, and giving people opportunity to know that and to be able to live well as they can in their last part of life.
And I think it's important to say that those conversations aren't necessarily something that us as ambulance clinicians should be having. It's the first time we've met them. It's likely not appropriate, but it's that referral, like you said, referring to a clinician that knows them to start the ball rolling on their advanced care planning in those conversations. So I think data has been a real sticking point from us, and I think the problem with that, and I think other services nationally share the same issues, is these patients don't come into our 999 triage service, and there's not a flag to identify them as palliative or end of life care. They often at times won't identify themselves as that, or family members won't identify. So we are very much reliant at the moment on clinicians coding and recognising that, but we do know that the data we have is massively underrepresentative of the population that we serve with this patient group, if we're thinking wider to that final 12 months of life. So we do get some data, and we do monitor the conveyance to hospital, the ED conveyance data. Not obviously a lot of the times it is absolutely appropriate, but from our program, at the end of our program, it's and even now it sits around 10% of this patient group conveys to the emergency department. We don't kind of drill down as to how many of those were appropriate versus inappropriate, but we kind of recognise that there'll always be a level of conveyance needed for this patient group and wanted by this patient group. We have the audit that obviously we track for quality of care and quality of documentation, and that's fed back on a kind of station-based level. And we also monitor our incidents and quality alerts that come into us from outside teams. So we have a real good idea of some of the themes of the issues that we identify. So a lot of it is around inappropriate resuscitation or inappropriate conveyance to hospital, as well as access to advanced care plans. Those are the kind of common themes that we see within our incidents that we work really hard with colleagues on debriefs, on education, with our stakeholders. So we take a real multi-pronged approach to improving the care and the experience for this patient group.
I think we should initially start by sort of thinking of what the last year of life likely looks like for somebody. And I think we need to remember everyone's individual, and this is by no means a prognostic factor in terms of what we're seeing. I think things will take their course of time, and we can't necessarily predict when somebody is entering the last year of their life, or at the end of their life sometimes. But I think things that we tend to normally see, I think I'd keep it at a more basic level within sort of palliative care in a community setting, is just a general decline in somebody's health. That could be as a result of their underlying condition, likely cancer that's progressing, or their dementia is significantly worsening. So we will see things like worsening symptoms, but we also see things more from a practical sense that we take into account. Are they able to do the things that they were able to do last month? For example, can they dress themselves? Can they wash themselves? Are they needing more assistance with a lot of these things? And you can progressively see that happening over a period of time. Other factors we take into consideration is disinterest in things, in food, in sort of family life, or things that they previously enjoyed, they might not enjoy it anymore. You might find that they're sleeping more often, for example. And as a palliative care nurse, that will tell me that things are starting to change. I think where the difficulty lies for the London ambulance services, they won't have that sort of background information that a palliative care nurse would have, or a GP service would have, or the district nurse, for example. They wouldn't have seen that patient trajectory over a period of time. And for them, that's where it can be quite difficult to predict whether what they're seeing is something that's acute and sudden, or, is this part and parcel of something that's been happening for a period of time. I think probably Rowena can pick this up for me, sort of from her perspective as a paramedic, in terms of when she attends somebody who probably is in the last year of their life, but for her can be quite a difficult scenario to unpick.
Yeah, I completely agree. I think it's really challenging for us as ambulance clinicians. We tend to sort of parachute into these situations, and we have to sort of make what I would term kind of a cold assessment. We don't know anything about this person. We don't know anything about their baseline. We have to establish all that, and we have to establish that really rapidly. And I think that can prove incredibly challenging because obviously what we see is in that immediate moment. And I think we rely really heavily, once we've done all those kind of immediate assessments, we rely very heavily on other healthcare professionals' documentation about that patient, which is why the change to using the iPads, getting access to all of those tools like the National Care Record Service, London Care Record, and the Universal Care Plan has been, I think, game-changing for our ability to appropriately assess and treat this patient group in particular. I think it's really helpful for multiple patient groups, but particularly this one, because we can read what the GP thinks, or their last sort of set of observations, even with the GP. We can read what the specialist teams have got to say about these patients. We can read discharge letters. And I think as generalist practitioners, we rely so heavily on the specialists like Natalie, who've written this documentation. And I just don't want people to underestimate how helpful that can be in supporting those decisions on scene, because we drop in out of nowhere, and we've got a really short space of time to assess these patients and to treat them appropriately. And I think that's really important.
Yeah, absolutely. And could I get you to both speak to, and maybe Rowena first, to the surprise question?
Yeah, of course. I know you spoke in the previous episode about the SPICT tool and how valuable that is. And the surprise question sits more within the gold standards framework, the prognostic indicator guidance, which London Ambulance Service don't use so much. We tend to advise using the SPICT. But I think the simplicity of the surprise question, for me, is wonderful. And I think we need to remember that we're not prognosticating that this patient is going to die in 12 months or within 12 months. It's about asking yourself that question: would I be surprised if this patient were to die within 12 months? And it just opens up your thinking to a new kind of narrative to consider what that patient needs, what's appropriate for that patient. Have they even been flagged by anybody else? I think as ambulance clinicians, we go to a lot of the sort of frail, elderly patients who've just dropped off the radar of every other service. And actually, we are often the first clinicians to note and observe that patient might be in the last 12 months of life. So it is absolutely our responsibility to flag that patient to their GP, to the hospital, whoever it might be. And I think that surprise question just gives you that little light bulb moment of, do I need to think about this patient in that way? And I think we're really afraid of that, because I think we worry that by saying, actually, no, I wouldn't be surprised, we are sort of consigning that patient to their death. And we're absolutely not. We're actually supporting that patient better. So for me, it's a really simple question to ask that leads you into using the SPICT, all of the other kind of little indicators, and finding that evidence that backs up that sort of, I want to say, gut instinct almost, that actually you think that patient might be coming towards the end of their life. And I think its beauty is in its simplicity, and I think it's just about guiding your thinking.
I mean, I think from a community perspective, shared decision making is vital. There's many, sort of influence the patient, or rather teams the patient will get to know while they're being cared for at home, for example, or be it in a nursing home. I think we need to remember the community services that are all available and all have an impact with this patient and all have something to contribute towards this patient's individualized care plan. And I think the importance of shared decision making is to make sure that everyone's on the same page about a patient, what their care plans are. And I think especially when we're dealing with teams that are very responsive, like London Ambulance Service, for example, I think it's very important that those decisions that have been made is known to them so that they can better support and manage these patients when they are called out to see them. And I think just also that sort of interaction with GP practices, for example, just making sure that we're all on the same page is absolutely vital to not only, support this patient group, but also to promote, I guess, our working together and sort of strengthen those relationships amongst ourselves as practitioners. So I think in terms of shared decision making, it's one of the vital aspects for all of us, for all practitioners in a patient's care.
It's about putting that patient in the centre and remembering that ultimately it's about their wishes and their preferences. And for example, quite a lot of dementia patients find going into hospital exceptionally distressing. And actually, is that the right place of care for them? So having that documented, that someone's had that conversation about that patient is a really good jump off point. But I'm sure a lot of clinicians will have been in the scenario where a family member says, no, they have to go to hospital, they have to get IV antibiotics. But actually, what does that look like for that patient? What does that look like for that family? The realities versus the perceptions, I think, is a massively important conversation that, again, we are all responsible for having. We hear on the news about how overwhelmed hospitals are, but actually, do you understand the reality of putting a dementia patient on a bed in a corridor for potentially getting IV antibiotics? And I think just being incredibly honest about that conversation, because expectations and reality don't always align. And I think having those really honest conversations in a really kind way, in a really humane way, with everybody on scene, bringing that family along with you, because you need to have their support. You can't be kind of dictating. I think you need to have everyone's buy-in to go down whichever route you're going. I'm not saying don't go to hospital. Sometimes you need to go to hospital, and that's absolutely the right thing to do, and we shouldn't be afraid of making that decision. But sometimes it isn't, and I think it's about weighing up all of those bits of information that you've gathered from all of those really important people, from specialists, from family, through the ACP, through those conversations, to hear that patient's voice, to really understand. But you've absolutely got to communicate, to take all of those people with you on that journey, and just be really honest. I think it always comes back to that level of honesty. And if you don't know, say you don't know. We don't have all the answers, and it's okay not to have all the answers. But just I think to be really honest about it.
Reversibility is also very challenging for us clinicians. They take form of things that are, sort of like opportunistic infections where there is treatment available. And I think sometimes it might be very hard to distinguish whether someone is starting to die or whether an opportunistic infection or, they're hypoglycemic, whether that's what's sort of really driving a lot of the change that you're noticing in the patient. I think we need to think and go back to, as Rowena says, what was the patient? What were their wishes? What did they want? Obviously, as a palliative care nurse, one of the first and foremost things, aside from individualizing that plan or thinking of the patient at the center of that decision, is what symptoms are they suffering from, and what can we alleviate now, and also just incorporating family into that decision, the GP or other services that might have been involved that might be able to give us a bit more information around what are the next steps, what should we do? Should we manage this within a home setting? Do we think that actually this person is just starting to die? Or is this something that we really need to take a bit more seriously and either convey into hospital potentially or start treating aggressively? But we need to remember, would that be the most appropriate plan for this person? Or do we need to have a bit more frank and honest conversations that maybe this is something that's just part and parcel of the natural process of them starting to die? So reversibility remains something that's very challenging. The one thing that I think I will say, and also will help sort of the ambulance clinicians, is that it's important for palliative care teams to recognize what is likely a reversible condition and to highlight that on the universal care plans. Specifically, if it's an infection, a UTI or a chest infection, this is what the management plan that they would foresee. And I think that would help clinicians, because just saying, take to hospital for reversible causes, I don't think quite helps an ambulance clinician. I think we need to be a bit more descriptive in sort of what we're highlighting. Yeah.
I'd really strongly second that. I think the term reversible, take to hospital for anything reversible. Well, anything's reversible, isn't it? If you drill down into it, and then you've got to get onto the really big question of, should it be? Is it appropriate for that patient for whatever it is to be reversed? And I think it's really important to remember that that is not a decision to be made in isolation ever, because they're huge, huge decisions. And I think for ambulance clinicians, most of us came into the job because we want to save life, to preserve life. And actually there's a huge shift from that survival focused care that is most of our work to the provision of that supportive comfort care. So it's a huge brain shift for us. And I think involving others in those decisions, as we've said so many times in this last 30, 45 minutes, it's just so important. And we just need to, phone a friend, use all of those tools that we have available to us. Phone a friend, have a conversation, be honest, be empathetic.
Well, what I'd like to start off with is recognising ambulance clinicians' role in this, and absolutely, as you said at the beginning of the episode, about how actually a lot of the times we are the first clinicians to perhaps even recognise that this patient is in these final stages of life. And that could be for a number of reasons: either the patient's not engaged with community services, or actually they've been kind of managing quite well at home and something's happened a little bit more suddenly, and therefore they've not had that interaction with people like the GP. But I suppose I'd kind of pass over to Natalie to talk about the signs and symptoms, because this is your bread and butter.
Yeah, thank you. I think the first thing we often need to remember and understand is we need to recognize that somebody is actually dying, that what we're seeing and what's in front of us is somebody sort of in the last stages of their lives. And that forms part of the bigger picture of the individualized care plan, which, sort of goes back into the ambitions that we spoke about in the last episode. The signs and symptoms are in part of the last year of life. That the signs, the symptoms that we discussed at that point in the last episode are quite similar. It'll probably be, the more common presentations would be somebody who has taken to bed, so they're less mobile, they have a significant functional decline. At this point, they're probably unconscious, they're not able to respond to you or let you know what their needs are. They might have audible upper airway secretions, because as we start to enter the last stages of our lives, we tend to manage our secretions less well. I think people commonly might refer to that as the death rattle, for example. The individual might look quite pale, they'll be quite cool to touch, and that just sort of feeds back to the body just starting to shut down and concentrate on the more vital organs. But having also said this, as we're quite individual and we're quite unique in our day-to-day lives as people anyways, not everyone will present this way. But these would be the common signs that we'd expect to see. There's some people who we might term as dying on their feet. So these might be people who are actually alert, they might be walking up and down, moving up and down, and then maybe 2 hours later, they probably end up dying. We would probably still recognize that they would be in the last stages of their lives, but everyone's unique in terms of how things progress for them. I don't know if you wanted to
No,
say.
yeah, I think what I was going to come in and say was, as ambulance clinicians, I think we kind of, our routine is to come and do a set of observations on these patients, and that's absolutely something that needs to be done for a lot of these patients, especially if we are the first ones recognising that they're entering this stage. We may well do a first set of observations, and I suppose from that standpoint, what we often find is that they will present with things like low oxygen saturations. They will have an increased respiratory rate. They will often have a very low blood pressure, be quite hypotensive, and be tachycardic as well. And I suppose our reflection of that is if you look at that in isolation of a patient that looks very unwell with those observations, and you don't have that history that Natalie was talking about, you can very much jump to, oh, this patient's potentially septic, or there's something very wrong and they're very sick and we need to transport. So I think it's really key what Natalie was saying is it's building that whole bigger picture, and that history taking is really going to lead you to signs that this person's dying if they've been engaging less in family, talking less, taken to bed, those kind of ones, the typical ones.
Yeah.
I appreciate what you're saying. We always get those atypical ones where things happen very suddenly, but it's that history taking is so key, isn't it, to build that picture.
Yeah.
So just looking, before we really move on, absolutely, and like you said, just really dialing down into the history. Could I get you to speak to maybe Natalie and or Karina, just some anticipatory medications that clinicians might be atypical to clinicians actually, but actually maybe quite familiar to palliative or end of life care teams, just that actually might be regular attenders. So just something which indeed the patient might be on as an anticipatory medication, such as, I guess in a way, really high strength painkillers such as maybe fentanyl or otherwise, which is, you know, really starting to offset some of those really chronic, now acute symptoms. Could I get you to speak to some of these medications?
Yeah, I think I'd probably talk about the more common medications that we might put into somebody's home. And we tend to do this preempting that somebody may be in the last stages of their life. Sometimes they're termed just in case medications as well. And we normally would only give them if they're necessary to give. So they would include, this would probably be the most common that you'd find in someone's home, would be an analgesic such as morphine, that's to help with pain or breathlessness. We'd also put in something to help with anti-sickness. Most commonly, that's haloperidol. That can differ depending on the patient's history as well. So we need to always be mindful that we're thinking about what are their comorbidities as well before putting these medications in the home. There'll be a sedative such as midazolam. This is often to help with things like agitation, for example. And the last medication that you might see would be glycopyrronium, which is to help with the secretion management. There are other drugs that we might put in place based off the patient's history, and that could be somebody, if we know somebody's on anti-epileptic medications, for example, we might want to put in an injectable form of that because we'd want to continue managing those symptoms at the end of life. But that is also very patient-specific or case-specific. And those particular medications wouldn't necessarily be known to the ambulance service. You know, they might have an idea of it, but they wouldn't necessarily be dealing with those particular medicines. But from a specialist palliative care background, we need to consider those medications if it's needed.
Yeah.
But I think with the ambulance service,
yeah, I think obviously we play a role in interacting with these medications, but absolutely we're not prescribing, and they're not familiar to us. A lot of ambulance clinicians, this will be the first time they're hearing of some of these medications. So I suppose our role is if these injectables, these anticipatory meds are in the person's home, depending on what trust and service you work for, a lot of paramedics can give these subcutaneously as and when required. I think a really important point is to recognise that these may well be in the house, but actually the patient might not need them. We know the research shows that a lot of patients towards the end of life do experience one or more of these symptoms, but actually you do often, I suppose, Natalie, you can talk to it, you do get these patients that don't require anything. They're there just in case, as Natalie said, but we might not need them. And I suppose a point that I think is important to make is that it's not always specialist palliative care that prescribe these, and actually the GP, certainly in the UK, should have kind of sole responsibility to prescribe these, and they come with a medication authorization chart, a medication administration and authorization chart, and that's something that the ambulance clinicians should be quite familiar with and be able to read and be able to document what kind of medications they're giving. And I suppose my tip as well is recognizing that we're not familiar with these drugs, is always share the decision before giving these medications, so we know medication errors can occur in these kind of high stress emotional environments. So that's something that we try to promote in our services. If you're not confident with giving these, not familiar with these drugs, is just doing your normal drug checks, but also sense check it with someone that knows the patient as well. But yeah, absolutely, there's a role for ambulance clinicians, because we're going to get called to these patients when they're dying, and when there's some sort of crisis, if they're having a pain crisis or breathlessness, we're going to be the ones that the family, the carers tend to call.
Yeah, absolutely. No, absolutely. And one of the aspects of the symptomatology that I recognized was just around noisy breathing, actually, and nothing more complex than, an elevated respiratory rate. But to Natalie's point, that might have been a feature for a while, but when that breathing becomes a lot more irregular and or noisy, even as you were saying before, even in younger patients with palliative and or end of life care, with in the dying phase, when there is a raised respiratory rate, and then maybe really in the last few moments, the respiratory rate starts to lessen and lessen and lessen, and that for me was a really acute sign, actually. Natalie, as you're saying, there's a lot of baseline observations which have clearly deviated for a long time, but that respiratory rate, elevation of the respiratory rate, and then almost the subsistence, and as it starts to lessen and lessen, really for me was a tangible, okay, this really, we are really in the last moments of life. And I don't know if that's been a anecdotal reflection or indeed experience of both of you, but that those respiratory changes being quite an acute marker, really.
Yeah, I probably should have been a bit more clear initially, but absolutely, breathing can be very distressing, especially for family or people who are watching, and it can present in a multitude of ways. There can be tachypnea, so higher respiratory rate, but equally there could be a much slower respiratory rate with apneic pauses in between, and those pauses can be quite prolonged, they can be quite short, and that can fluctuate throughout. And equally, the noisy breathing, the upper airway secretions, that tends to be significantly distressing for family, because we've all heard it, and it definitely can sound like somebody is struggling to get air in, and it's one of the most basic things is breathing, isn't it? And for an individual who doesn't have a medical background, hearing that, it can be very distressing, but oftentimes it's quite important to look at the individual in front of you and try to establish, are they in any discomfort? Are they showing any signs of distress, such as frowning? Are they groaning? And sometimes in those cases, actually, they're quite comfortable, even though the secretion, that the noisy breathing is present. We just find that sometimes the secretions sit quite higher up, and can be quite difficult to manage. But actually, it is not causing distress, and it's important in those moments to reassure the family at that point in time that we can give something for this, but it's unlikely that it will help. But in some cases, it might. But also to sort of support them with their fears and their concerns, and just try and manage that, and explain to them, this is what we can do, but this is what might continue to happen. But absolutely, breathing can be very distressing. And I think that's probably one of the reasons family might call for an ambulance, actually, is their breathing has changed.
Yeah, I think that's a key one, is either they've got so they're in distress, the breathing's changed, or actually they're becoming more unconscious and less responsive. And that's often where we get called in to these kind of situations.
Yes.
Yeah, it kind of leads me quite nicely on to the next question, actually. Just around carer acopia, or just the feeling of not being able to cope, just through it, like you said, through the longevity of days, nights, weekends, and just this really emotive period, really, for family members and primary carers. Could I get you to both speak to, really, indeed, Karina, maybe yourself, and then Natalie, around just some of the reasons why we get called to patients in the end of life and stages of care, and indeed, just, yeah, you've mentioned already just this, the change in breathing, the change in conscious level, the family distress, sometimes denial, which again is extremely difficult. Could I get to speak to these presentations? I'd love to hear both of your thoughts, actually. Karina, to you first.
Yeah, I suppose my experience and from working in the service and having all these debriefs with our clinicians about it is absolutely that the family will call when there is that sudden acute changing condition, like we talked about, the unconscious or some kind of uncontrolled symptoms coming up, and if it's 3 a.m, they know they're going to get a response from us as opposed to any other service. We're going to get there the quickest. I think in terms of the kind of family distress or carer kind of breakdown area, I think what I've recognised, or what my experience is that you can prepare a family as much as you want, but actually the reality of their loved one there dying in the home in front of them is a very different reality. And actually, I think it's all well and good and absolutely important to make these plans and know what your loved one wants. But if you don't have that care support structure at home, or actually it's too distressing for that family, then that's when perhaps we get called as an ambulance service and we need to be looking at the other options. And I think we can sometimes think, oh no, that's not what the patient wanted. But actually, if the family's not coping and they're not going to get the care they need at home, that's then when we need to start looking at other options. But I suppose, Natalie, this is absolutely your area. What's been your experience?
I mean, I'll probably say the same thing. I think what people don't realize is the emotional burden of looking after somebody who is actually dying. And it's also thinking about the finality of death. I think a lot of people are very much on board and saying, yes, I'll look after my loved one at home. But when reality starts to kick in, the picture starts to change. The amount of probably physical labor that they might need to support that family member with, or the emotional burden, all sort of comes to head. And yes, that's when they might call for emergency services, just because there's probably nowhere to turn. And sometimes it might just be that they needed somebody to come and tell them, actually, you're doing the correct thing. And maybe that might settle their fears. But sometimes, as Karina said, maybe we really need to think about, is this the right place for this person to stay? Have we managed or put all the support in place that is possible to put in the home setting for this person, to help them keep their loved one at home, if that was the loved one's wish? But equally, then we might need to think about, do they need to go somewhere else? Do we need to consider a hospice? Do we need to consider hospital, depending on the urgency of the situation? But then equally, we need to think about the journey. Is that journey moving this patient to another area? Yeah. Will that be distressing for them? So it can be quite difficult situations to manage. But I think it really does boil down to what Karina has also just said, in terms of people don't understand what they're in for until they're facing it, and then the reality of death hits them, and then the grief is already starting before somebody's died. Yeah.
I think communication there's key. I think once we recognise that a patient's in that dying phase, it's about, and I know we're going to be talking about communication a bit later, but I suppose it's about managing expectations and explaining the process of death in a way that families can understand and know what to expect and what's happening next. And that can help inform them about a decision of, okay, can I cope with this? Do I need more care support at home? And then figuring out how we can support that.
Yeah, absolutely. I couldn't agree more, actually. And that communication piece, we'll go there in a short while. But just before we move on, really, to maybe some of the absolute fundamental challenges when supporting patients in the final weeks or days of life, could I, before we go there, could I just get you to speak to terminal agitation? Because I think sometimes, like we said, the respiratory rate is one thing, conscious level is another. And to your point, to both of your points, really, about the distress of seeing an agitated patient, actually, like you said, it fundamentally probably hypoxic in a way, and just that hypoxic agitation, really, which is acute confusion, chronic to acute confusion, but overlaid with the hypoxia, and is maybe, like you said, just the last few sensors within the brain, the respiratory centers sort of really shutting down, and that, to your point, Karina, really about, I guess, in a way, bringing the family along, that this is normal, this will happen. They are becoming a bit more confused or agitated. It's something which is to be expected, and kind of aligning expectations there. Natalie, could I get you to speak to that?
Yeah. Terminal agitation is very distressing. We've probably seen it quite a few times ourselves. And it can present in a multitude of ways. I think Karina and I actually this morning were just talking about, sometimes people live how they die, and there are people who are quite busy, people who were mobile, who walked around, who kept themselves very busy. Sometimes that might emulate in their last hours of life, where they're trying to get out of bed, they're trying to reach out. And I think sometimes the issue with this particular scenario is family think that I can talk to them, we can calm them down, but in reality, you can't calm them down. You need support from a healthcare professional to manage this particular situation, and that tends to add to more so to their distress when they see their family in distress. When there's a picture of, I think we all have an idea that we'll fall asleep and die. And a lot of people want that for their loved ones. And so for them to see somebody so agitated, screaming out, trying to get out of the bed, trying to mobilize, with whatever last energy that they've got, they're trying to, get somewhere, not listening to their family, that can have such a strong impact on the family's grief following that, or that they just have that guilt or that sense of, I didn't look after them the way they wanted to be looked after in their last days of life. So it can be a very distressing picture, and this is oftentimes where probably the ambulance service comes in a little bit, just because they respond slightly quicker, probably to a palliative care team, where they're quite helpful in terms of managing this particular situation. And obviously, if this is a patient that unfortunately is not known locally to the palliative care or to a GP service, that picture can also add to more confusion and to more distress, and it's just trying to figure out how best do we manage this situation. But terminal agitation,
it's a really tricky one, isn't it? I suppose how I always saw it, and it's really interesting hearing Natalie, your view about the extreme of where they're trying to get out of the bed and scream. And when I think terminal agitation, I think of a patient that's conscious but not kind of getting out of the bed and just picking at the bed sheets, which is obviously a lot easier to manage than someone that you're describing. And I think my reflections on how we would manage that as an ambulance service is, obviously it's lovely if they've got anticipatory meds and they've got that midazolam in there for agitation. What I've learned is really key is communication with the family before you give that midazolam, and actually explaining to them that once I give this midazolam, this isn't going to hasten death in any way, but actually, because we're relaxing them so much, the thing that's keeping them awake at the moment is that agitation. Once I give this midazolam, they may well not wake up again. They may go unconscious, and then their body's so relaxed, then it may allow them to die. So I think that's really important to communicate that with the family, because that is the last time potentially, if it is real, true kind of end stage terminal agitation, that's the last time they might get a chance to say things to their family member while they're alert, so even though they're not fully aware. That's the word. Absolutely. So that's kind of my key learning. And I suppose also, I know this is the context of the dying patient, it's also making sure your history is suggesting that, and they're not having like delirium, which is absolutely treatable and isn't a terminal event and there's many reasons for delirium, which is another episode. But it's putting it into context of the whole of the rest of the history is suggesting terminal agitation as opposed to delirium.
And that's a very good point, because it equally, I've also had situations where I believe it's terminal agitation, but equally this might be somebody who has quite end-stage dementia and is very confused. And that picture can be very confusing to a healthcare professional. And it's, should I sedate this person? Is it appropriate to sedate them? And I guess that goes back to the shared decision-making, the history checking, making sure what you're seeing in front of you is this or
is there a cause? Have they got constipation, urinary retention? Have they got a pressure sore that's causing all of this? It's really, really tricky area, but shared decision making, absolutely. I would always, if I'm thinking of giving midazolam, I would always sense check that, because we don't just want to be sedating people when they're in pain or distress for another cause.
Could be another reason.
Yeah, listen, I totally agree with absolutely both of what you're saying, and let's go there really, because there's more to the conversation around, like you said, reversibility versus the dying patient. And I think that's to your point, Karina, and to yourself, Natalie, it's really, I think that shared decision making is absolutely fundamental, because it's such a crucial decision. Is, do we, like we said, offset and or mitigate some of the symptomatology, or do we directly treat? Is it a low blood sugar? Are they hypoglycemic and actually that's treatable? We should treat it, versus sedation and or expediting just the sedation just to give someone a death. So there is, like you said, there's reversible causes, and there's maybe understanding this is the true organic nature of metastatic multi-organ cancer, which is actually taking hold of the body and actually probably shouldn't be reversed. And actually, and I might be opening a can of worms here, but it's actually, I'd be interested to know, reversing a profound dose of morphine, it might not be the best thing to do, because actually if that morphine is there for a reason to mitigate pain, and there is some semblance of pinpoint pupils, or there's a semblance that the patient's still alive, but in a really sedated place, actually understanding that maybe those opiates are there for a reason, and not reversing an opiate, a strong opiate medication, because it's doing a job for mitigating a whole cadre of painful symptoms. And I guess to your underlying fundamental point, you both said this, it's share before you step forward with any medication. The more I think you're in practice, the more you realize your fallibility, and sharing these decisions, saying, look, we've got A, should I do B, C, or D, and understanding that and sharing that. But could I get you to both just speak to the appropriation, reversibility versus non-reversibility? I think the MDT approach, multidisciplinary team approach, is key. Bringing the family along, as you said, is key, but also, I guess in a way, understanding, like you said before, Natalie, the trajectory of care. Could I just throw it out to you, and then we'll kind of move on?
That's a big question, isn't it? And it's something I think we always debate and struggle with within the ambulance service, because it is the conundrum. We call it the conundrum. I guess my initial reflection, I'm going to hand over to Natalie to talk about the opioid toxicity point that you brought up, is absolutely it's looking at the history, it's looking at that person as a whole, and it's thinking about, is this a likely cause of that disease progression? So we know, for example, patients with advanced dementia, the main mode of death is aspiration pneumonia. We know that is, you're not dying of the dementia, you're dying as a result of the causes that the dementia does and how that affects. And we know a lot of mode of death for these people will be infections as well. So I think the biggest debate we have is sepsis versus dying. And the question that comes up is, can it be reversed? Which anything can potentially be reversed. Cardiac arrest can be reversed. But the key question that we, I think, put on ourselves too much is, should it be reversed? And actually, that's not a decision that an ambulance clinician that has just met this patient should ever be making in silo. And that's why we really, really push this MDT approach, this shared decision making, because that is one of the most difficult, I think it is the most difficult call for an ambulance clinician to make, is what are we going to treat and take this patient, or are we going to go down that dying route? We don't have a simple answer for that, other than what you've just summarised is shared decision making, speak to the family, getting that really good history and that context. But yeah, they're my initial reflections. I don't know if you want to come in, Natalie.
No, I agree. It's very difficult and it's very case specific. I think you need to know what the environment you're in is presenting you with and what information. So unfortunately, there's no clear answer that I can give anyone or we can give anyone about what decision you're going to make at then at the time. I think in relation to opioid toxicity and reversing that, equally that is also very case specific. I don't want to sit here and say that we've never reversed an opioid toxicity. I think in palliative care, we generally look at respiratory rate and saturations. Sometimes pinpoint pupils don't always give us the most clearest answer that somebody is toxic necessarily, until we notice that respiratory depression and low saturations. Those are the times that probably we might action. But that equally is a very difficult decision, and that often or all the time needs a more senior oversight, because as you said already, you don't want to reverse something where you've given it to treat something, and you know that the fact that you're going to reverse it will cause more distress and discomfort. It's just going back to what Karina said, it's important to involve the family in those kind of situations as well, to explain this is what's happening, this is what we're planning on doing, or who we're going to talk to about what we do next. But yes, reversibility, as Karina said, there's always something to reverse. If you look very hard for it, you will find it.
Yeah, that's the problem.
That's the thing.
And I think, yeah, we do, aren't we? As ambulance clinicians and paramedics, we want to help and reverse, but it's that should we reverse question. Exactly. And that's when we involve other people in that decision.
Yes.
That knows the patient. Yeah.
But I think just because you mentioned diabetes, I will just highlight that there is a national guidance on diabetes at end of life and in the management of that in the last days of life. So anyone can access it with a quick Google search, just to inform yourself, just to give you a bit of understanding around that.
Okay, that's it for this week. I hope you enjoyed that compilation. Like I said before, there is a fantastic 4th episode that you can gain access to on the show notes, and that's really on palliative care case studies. And we do a really deep dive into some of the most challenging cases that can be confronted within and indeed experienced in pre-hospital care. So please do go away and check that out. We'll catch you on Monday for the next interview episode. On Monday, we're going to be talking about community emergency medicine with the medical director of Essex and Hertfordshire Ambulance, Tony Joy. But please do rate and review the podcast, and indeed check out the other episode on the podcast. And we'll catch you again on Monday. Thanks again.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.